Thank you, Dr. Devi, for that insightful session. Now I am honored to introduce Dr. Amit Dua, Professor and HOD Guwahati Hospital, an interventional pain management expert. Please welcome Dr. Dua to the dais for his presentation on Ganglion Impar block. Welcome, sir.
At the outset, I thank the ICRA team and the chairpersons for inviting me here. I'm Colonel Amit Dua. I'm HOD Anesthesia and a pain physician at 151 Base Hospital, Guwahati. Greetings from my hospital to everybody. We know we are at the fag end of the cancer pain session, but I still feel one of the most important sessions is cancer pain, always. For a chronic pain physician or a palliative care physician, we need to manage cancer pain. A lot of my part has already been covered by previous speakers, so I'll be talking very relevant things. So where did the name Ganglion Impar come from? Ganglion, we know, is a group of neurons or neuronal cell bodies in the peripheral nervous system, and impar is a Latin word which means unpaired or azygous. So it very clearly says that it's the only unpaired sympathetic ganglia of our body. And another name of it is Walther's ganglia, because it was first described by Dr. John Jacob Walther in the 18th century. He was a German anatomist. So the location, as I already said, it's a large sympathetic ganglia formed by the fusion of the two prevertebral sympathetic chains. It lies ventral to the sacrococcygeal junction or in front of first or second coccygeal vertebra. The location can vary. The size is very small, just 4 mm. That is why we tend to miss it many times during our interventions, and it's lying in the retroperitoneal space. So the contents, the efferents are somatic and sympathetic nerve fibers from the perineum, rectum, and genitalia, and the efferents, being a sympathetic ganglia, the efferents are purely sympathetic and nociceptive, because nociceptive fibers are being carried by sympathetic ganglia or the sympathetic fibers here, and they supply to the perineum, anal region, and the internal pelvic organs. Somatic efferents to the same efferents, to the same areas also go via this, but they don't stay there. So it is mainly a purely sympathetic ganglia which supplies the perineal organs and the genitalia. So it is very, very important to understand this part of the anatomy and a little bit of the autonomic nervous system before we actually go into doing this block. The block is actually not very difficult, but to understand the anatomy and physiology of ganglion impar is more important than the block itself. Then we have a higher chance of success. So why do we do a ganglion impar block? To alleviate the chronic and cancer sympathetic mediated pain caused in the same regions where it supplies. The drugs which we can use, local anesthetic and steroids, we can use radiofrequency ablation, and we can do neurolysis. Since we are talking about cancer pain here, I'll be talking more about radiofrequency ablation and neurolysis. Actually, neurolysis is something which we need to do when it comes to cancer pain. Contraindications, we all know, local or systemic infections, coagulopathy, distorted anatomy. So the two most common approaches, there are many, many approaches which have been said in the literature, but the most common approaches are the lateral or the transsacrococcygeal approach. The lateral approach was described by Plancarte in 1990. And it's a very interesting approach. Patient lies in the left or a lateral decubitus position. A 22 gauge 3.5 inch needle is bent 25 to 30 degrees, as shown in the pictures next to it. You infiltrate the coccyx with local anesthetic, go through the anococcygeal ligament, and you place your C-arm in a PA position to the table. Insert the needle anterior to the coccyx through the anococcygeal ligament. You can see in the picture below, the needle is coming through the anococcygeal ligament and comes to the anterior side of the sacrococcygeal junction. The concavity is posteriorly till it reaches the sacrococcygeal junction retroperitoneally. Then you give the dye, confirm your position, and once you're there, you can give the drug. The issues very commonly and very obviously seen is that you can penetrate the rectum or the anal canal, and it is said to be safe. The one finger should be in the anal canal just to make sure you do not penetrate it. So it is something which is not used very often nowadays because there's a much easier technique available, much easier, much faster technique available, which I'll be talking about. So now coming to the transsacrococcygeal approach, which was described by Wem and Sebersky in 1995. Very simple, very effective approach, very rare to miss it. Patient is in prone position, C-arm is in AP, we mark the sacrococcygeal junction and the midline. Very, very important step. Many a times we feel that the ganglion impar block is done only in lateral position, but before we turn the C-arm lateral, we must make sure that we have identified the midline. So that is why this picture shows that the person performing the block is making sure that he is in the midline. Then you turn the C-arm laterally, infiltrate the skin over the sacrococcygeal junction, bend the needle 10 to 15 degrees, just to make sure that if your point of entry is little away from your target, you don't have to come back to the skin again. You can just manipulate your needle while you're still inside, and you can do a successful block. So these are the 3 steps. Usually we enter through the sacrococcygeal junction. There are usually ligaments, posterior and anterior sacrococcygeal ligaments. You need to pierce both of them, and you need to, the moment you enter anteriorly, you need to stop there because you want to prevent entering into the rectum. The moment you come here, you give some amount of dye. Reverse comma sign is a very commonly used term for this. You make sure again in the AP view that you are bang in the midline. You can see here, I have taken the AP view and my dye spread is bang in the midline. Only once I'm sure of this will I give my drug. So for a diagnostic block, you can give a local anesthetic or a steroid. When you have to go for a neurolytic block, you can use phenol, you can use alcohol, depending upon what is available to you and what you are comfortable with. Coming to radiofrequency ablation, not very frequently used for cancer pain, but yes, for chronic pains, you do want to use radiofrequency ablation. Many a times people combine RF ablation along with neurolysis, with chemical neurolysis. So in the RF ablation, you have to go through sacrococcygeal junction the way we were doing with one single needle, and another needle is passed either between S5 and S4 and S5, or between C1 and C2, whichever space is better and wherever you are comfortable anatomically. Once you pass the needles, you confirm again with the, make sure that you are in the midline, confirm with the dye spread, and then you can do a conventional radiofrequency. You can go up to 70 to 80 degrees for 90 seconds and do a neurolysis there. So these are the usual techniques. So now coming back to the anatomy part, if you know, ganglion impar is a purely sympathetic ganglia, and we do not have any gray rami communicantis coming there. Very, very important points needs to be understood. Last half a minute I'll spend upon them. The last gray rami communicantis starts from L2 and ends at superior hypogastric ganglion. So many a times, even after doing a ganglion impar block, the patient may still have some residual pain. That is when people recommend that along with ganglion impar, it is a good idea to do a superior hypogastric block also, because the gray rami have ended there. It is only the white rami which are, the white rami have ended there, only the gray rami, which is the postganglionic fibers, are the ones which are coming to the ganglion impar. So we might miss a little bit of the sympathetic supply, which is coming from the L2 level if we don't do the superior hypogastric block. So in cancer pain, many times it is recommended that you should combine the ganglion impar block with the superior hypogastric block. It is really handy and it is very effective. I have finished. Any questions, I'll be happy to answer. Thank you.
Thank you, sir. Questions we will take at the end of sessions.
Thank you, Dua, sir. That was an excellent lecture. Now we'll move on to our next session. Dr. Abhiroop Naik, a pain specialist with a focus on chronic pain, cancer pain, and MSK ultrasound. He will focus on stellate ganglion.